I'm Khosrow Adeli from the Hospital for Sick Children, University of Toronto. I have the pleasure of moderating this session, this rather interesting workshop on a very important clinical problem that has very important, that highlights the really important role of the lab in its diagnosis and assessment. As we will hear from three speakers, Dr. Zaritsky, Dr. Kellogg, and myself, this is an important, potentially lethal condition that if not diagnosed in childhood, and in many cases in the past has gone undiagnosed, it can lead to a significant disability and premature death in infants. So therefore, there is particular importance in its early diagnosis, and this is helped by appropriate use of reference intervals in biochemical diagnosis of this disease. So what is this condition? Well, we'll hear a good review from Dr. Zaritsky, but briefly, hypophosphatase is an inherited metabolic disorder that is caused by the loss of function mutations in a gene called ALPL, which is basically the gene that expresses the alkaline phosphatase protein or enzyme, and this leads to very low alkaline phosphatase activity, enzyme activity, and low levels of ALP is the hallmark of this disease in terms of its biochemical features. As you well know, we typically are very concerned with high levels of alkaline phosphatase and not low levels. Therefore, most labs are not that aware or interested in low levels, and in many cases, people are using reference intervals with a lower limit of 0, which means they will miss any low levels of alkaline phosphatase. So we're going to today talk about, first of all, the disease, its clinical and biochemical features. Then we're going to talk about the role of the lab and the appropriate use of reference intervals in its diagnosis. I should highlight that there are going to be, you have in your handout copies of all the slides. You also have a question card, basically a card to write your questions, but you're also welcome to get up and use the microphone either way. If you want to use the card, please just wave it and someone will pick it up from you. So before further delay, I'm going to start by actually, well, you have the program. We're going to start with Dr. Zaritsky, myself, and then Dr. Kellogg. And then we're going to have a panel discussion at the end. So please stay for that so that we can have a discussion and answer any questions you might have. I already sort of briefly mentioned this as to what HPP is and why we're interested in low alkaline phosphatase activity. These are the learning objectives, and basically we're going to define the condition, we're going to look at the role of the lab, and the importance of appropriate pediatric reference intervals in assessing this condition and diagnosing it appropriately. This program, by the way, is accredited, Accent CE accredited, and therefore you are eligible for Accent credits. But in order to obtain these credits, you would need to go to the AACC website, and I think there is information in your handout as to how to go and obtain your certificate. Okay, so well, I guess one last point is that today's, because it's so early and only some people could make it, this program is being recorded. It will be put on the AACC website in the next few weeks and in its entirety, and so will be available for many others to view. So our first speaker, as I mentioned, is Dr. Joshua Zaritsky, who is a pediatrician, actually a pediatric nephrologist in Wilmington, Delaware. Dr. Zaritsky has a lot of interest in inherited metabolic disorders, and this is one condition that has particularly been a focus in recent years, hypophosphatase. We're going to hear an excellent review of this condition from Dr. Zaritsky. Please.
I'll start off by saying that I love interacting with our lab members, and this is a chance, really. You can't make a diagnosis if you don't think of the diagnosis, and this is a chance actually for the lab to kind of reach out to the practitioners and say, hey, there's something quite not right here. And to really educate clinicians about this disorder, and you're essentially on the forefront of making this diagnosis, and I'll explain why in the subsequent slides. But my job in a brief 15 minutes is to kind of review the pathophysiology of hypophosphatasia, and I think with a good understanding of the pathophysiology, you'll really understand the clinical manifestations. And I'll talk briefly on the importance of making an early and accurate diagnosis. And this is something as a nephrologist, I deal with stuff that's sometimes I need to make a very accurate diagnosis, but often, it doesn't matter if it's a what type of glomerulonephritis is. I'm going to treat it all the same. Here, if you don't make the right diagnosis and you apply the wrong treatment, you're going to hurt the patient. So I'll talk a little bit about more. And then, of course, why we're here is how do you make the diagnosis of hypophosphatasia or HPP? So, just an overview of the disorder. It's important to recognize a lot of times you'll think, well, it's just a bone disorder. Well, it's not just a bone disorder. It's really a systemic and unfortunately progressive life-threatening disorder. And it's caused, the pathophysiology is rather simple. It's basically there's inactivating mutations in the gene encoding the tissue nonspecific alkaline phosphatase. And the hallmark, therefore, which makes sense if you knock out the gene encoding the tissue nonspecific alkaline phosphatase, is you have a low alkaline phosphatase. The question is, who's paying attention to having a low alkaline phosphatase? I can't tell you how many calls I get from outside docs. I'm sort of one of the metabolic bone specialists. This alk phos is high, 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 high. I don't receive any calls about low ones. I'm the one who's looking. And then we'll also talk about, once you understand the pathophysiology of what the enzyme does, well, how do you make the diagnosis? Obviously, you're going to have low levels of the product of the enzyme, but you're going to see buildup of the substrates. And we'll talk about PLP, which is vitamin B6, another thing that's fairly simple to measure, and then some of the less, I'll say, easily measured stuff, especially urinary PEA, as helping to confirm the diagnosis of HPP. So, like I reviewed before, the mechanism is fairly simple. There's a mutation in the gene encoding tissue nonspecific alkaline phosphatase. I won't go into a lot of the genotype-phenotype correlations, but therefore you have a low alkaline phosphatase, and then the hallmark of the disease is low alk phos when you measure it in the serum. You see the substrate accumulation. I'll explain how these substrates builds up, and this leads to the clinical spectrum, this systemic disease of hypophosphatasia. So here, I've been kind of taught, and I like this approach where I kind of pick out some very key slides and kind of drill them in. This is one of the key slides here. Really understanding, if you can if you understand this slide, you really understand the pathophysiology of the disease, and everything will flow from it. So normally, I like to think of bone as having sort of concrete and rebarb. The rebarb is provided by collagen, the collagen fibers. And there's diseases of collagen, such as osteogenesis imperfecta. Here we're talking about a disease of the concrete, which is basically the calcium phosphorus kind of matrix that gets into the rebarb. How is that produced? Well, bone is able to take an organic form of phosphate, pyrophosphate, extrude it, then the tissue nonspecific alkaline phosphatase basically converts that organic form of phosphorus into inorganic phosphorus. That then complexes with calcium and forms crystals. You get this hydroxyapatite, and this is what mineralizes bone. So any defect in this process is going to lead to undermineralized bone. And you can imagine now, if I take out that enzyme through a genetic mutation, well, what's going to happen? You're not going to have enough substrate. You're not going to be able to produce significant amounts of inorganic phosphorus to form hydroxyapatite. It's even worse than that, though, because due to the normal kind of feedback mechanisms that you have, pyrophosphate itself serves to inhibit the crystallization. So by having, not only do you not have enough substrate, but the buildup of pyrophosphate also worsens the condition. And so it's sort of like a double whammy where you're no longer able to form that concrete in your bone, and you can imagine what's going to happen. You're not going to be able to ossify your bone. So you'll have the flexible rebar, but you just don't have that concrete to solidify everything. And this just kind of demonstrates that here. So you have poor bone mineralization, and not only that, but now this calcium and phosphorus is not in bone. Where's it going to go? It's going to end up being in the serum. And then you'll see some of the renal manifestations later. So we also recognize that tissue nonspecific alkaline phosphatase plays a critical role in the nervous system. Now, when we look at the spectrum of disease, right, we see a variety of inactivating mutations. Sort of the worst is the patients who have the lowest level of tissue nonspecific alkaline phosphatase also have this neurological phenotype. And in essence, one of the critical vitamins, B6, the active form, PLP, is only able to make it into the cell after conversion through the tissue nonspecific alkaline phosphatase into another isoform. That then enters the cell. So you can once again imagine that without having the tissue nonspecific alkaline phosphatase, what happens? You're no longer able to maintain those levels of PLP inside the cell, and it's a critical precursor to several neurotransmitters, and the patients develop this kind of intractable seizure disorders. That's only responsible to peroxidine, which is a soluble form of vitamin B6 that's able to cross over the blood-brain barrier. Okay? So, and like I said, we see this in the worst of the worst cases. And unfortunately, it's such a severe seizure disorder, it's resistant to all other forms of treatment. So you really have to have someone who's, thinks about the diagnosis to make it, to be able to effectively treat these patients. So here I've kind of already given you some clues about the systemic manifestations. We've talked obviously about that if you're not able to form the concrete, you see hypomineralization. I'll talk a little bit about craniosynostosis. But the other thing we recognize for children, right, they have active growing bone. They're actively laying down calcium and phosphorus to grow their bones. So without that matrix, right, they're going to develop the hallmarks of rickets. Once again, I mentioned that you're going to have a buildup of substrate. One of them is just simple calcium. So the patients can become overtly hypercalcemic, with the kidneys trying to deal with the excess calcium. That calcium then goes through the urine, and they can develop nephrocalcinosis. I've talked about some of the neurological findings. It turns out actually that for the patients most severely affected, you can imagine, what do they actually succumb to? Most of the time, it's respiratory failure. Why is that? Well, you recognize that for the rib cage to act normally, you need ossified ribs, right? You need something for the diaphragm to pull upon. You need that bellows action. Without having ossified bones in your rib cage, this is what most of the patients die from early on. And I'll show you some rather horrific-looking chest x-rays. If the patient's able to make it through that kind of neonatal period or perinatal period, we do see some problems. We recognize this kind of interaction between muscle and bone. Without strong bone, you can't have strong muscle, and vice versa. So these patients also have hypotonia, and they usually have delayed or missed milestones. And then I also mentioned this hypercalcemia and this overall failure to thrive. So this is another key slide here. And so, any disorder that you want to, well, what happens to the patients? And this shows you that patients with some of the severe forms of HPP, specifically the perinatal and infantile forms, when you look at their natural history, look at their survival curve. Basically, at 4 years, only a third of the patients are still alive. So that's a devastating systemic disease, right? And it's not a disease that you want to miss. We're not talking about a survival of 90%. Rather, we're talking about a survival of only 30%. And just like I mentioned before, if patients have seizures early on, indicating probably the most severe form of the disease, these patients are almost universally dead by this age. So a very severe systemic disease. Here's some of the skeletal abnormalities I was talking about. You can imagine, if you look here, you can almost barely make out any ribs. And unfortunately, it's a progressive disease, so that we depend on our skeleton growing, further mineralizations happen. You look what happens eventually. Here's a patient at 33 months. It's almost as like, what's supporting that rib cage? There's no ribs there. I'll show you some of the pathognomonic findings that you really have to have a radiologist who's also looking to make this diagnosis to pick it up. But they'll have these very unique kind of Bowdler spurs. These can actually happen in utero. So if you have a very astute perinatologist, you can pick them up here. Some of the other findings, you can see this profound hypomineralization, which is progressive. So it's almost as if the patient is kind of washing their bones out in front of you. And look at this patient at 33 months. There's not even enough structural support for the bones to support the soft tissue. So this patient's never going to walk with these type of bones. But you start to see this kind of folding of the skin tissue just because there's no structural support. One of the other things that we're a little less clear of why happens is that in addition to sometimes seeing seizures, these patients will develop craniosynostosis, which is premature fusion of the sutures. And obviously we depend, as the skull grows, we depend on these sutures remaining open for a period of time so the skull has room to grow and accommodate the developing brain. What can happen, though, for unclear reasons, is patients with HPP will develop premature fusion of these sutures. And we very rarely check X-rays anymore, but this is the classic finding of this. Due to increased intracranial pressure, you start to see this kind of copper-beaten or beaten copper phenotype on X-ray. Nowadays, it's largely been replaced by 3D CT scans, but craniosynostosis, which can happen for a variety of other reasons, is fairly prominent in these infantile forms. If you're able to make it out of the perinatal infantile period and make it into sort of what later on in life, you're then given the diagnosis of juvenile or later on adult HPP. But we have to recognize the systemic manifestations remain. The disease just doesn't get better. We just see a different manifestation of the disease. One of the more prominent things we see is premature loss of their baby teeth. And I have children, so I've been through the tooth fairy. I can attest to inflation now. We've gone up from I think $1 a tooth to $5 a tooth, something like that. And here, though, as opposed to this little nubbin of tooth that you get, because what is actually happening is your adult tooth is kind of pushing, eroding away at the root of that baby tooth. Here, what we see is because of the poor cementing of that tooth in, the whole tooth comes out. So you don't just get this little nubbin of a tooth that pops out. You actually see the whole tooth root intact. And in fact, it's such an unusual occurrence to lose your tooth that way that a lot of times it's the dentist who will make this diagnosis. They'll recognize this isn't the way people lose their baby teeth. And they're the ones who will come to us, and the astute dentists out there will say, hey, there's something wrong with this patient. I shouldn't be seeing this. You need to go see a metabolic bone doctor. Obviously, with the skeletal, we talked about hypomineralization, the craniosynostosis, and the rickets. Here we start to see, as the kid is mobile, you can imagine that they're much more prone to fractures. And the thing that's unique about these fractures is they'll have a fracture, it will be set, but it will not heal correctly, and it will break again. They'll have a recurrent fracture. And that's a real kind of red flag for anybody in metabolic bone, is a non-healing fracture. The renal I've talked about, and then this idea of this muscular pain, you can imagine without having proper bone strength, you develop muscle strength, and you can develop a myopathy. This is the thing that kind of, when you look at patients who are able to make it into later life, this is what they're complaining about. They're complaining about muscle and bone pain, and it's limiting. A lot of patients end up in wheelchairs using crutches. I didn't get into it, but sometimes the pyrophosphate itself can accumulate in joint spaces, and they can develop rheumatological pain. And hypercalcemia always remains a problem, because if you're not able to put calcium in the bone, it has no other place to go. Remember, bone is the major reservoir for calcium. Here are some of the later radiographic findings. You can see, just like any other form of, when you have a growing skeleton and you don't provide sufficient calcium, phosphorus, or you're not able to make that matrix, you develop rickets. So you have the classic findings of rickets here. So this you couldn't tell the difference between this type of rickets and vitamin D deficient rickets. But in addition, you start to see these very unique features, especially this metaphyseal tongue, where you start to see this portion of cartilage that moves into the long bones here, and you get this kind of tongue of radiolucency. And then eventually, you start to see the bone just doesn't have enough structural support. And we start to see these horrible either valgus or varus deformities. This is just to remind you to say that, if you say, well, the child made it, they're going to do okay. Well, that's not true. These patients suffer from and a lot of times silently, they suffer from pain and disability. This is something that I recognize. A lot of times, as a child, it's the parent who's advocating for the child. So when I see, it's the parent who brings it, there's something not right with my child. I know they're in pain, they're not walking. As these patients get older, they grow up, they're expected to take care of themselves. Eventually, they just learn to live with the pain. They go to enough doctors, they've been misdiagnosed enough, sometimes they end up in, they can end up in any variety of pain management clinics, and they eventually just kind of give up on going to the doctor. And I know this with patients with, I see, when the parent's there, I can treat them and try to deal with them as best as possible. But once they mature, they go to an adult doctor who have less familiarity with his diseases, they just kind of learn to live with the pain. But you can look here, look how many patients, pediatric patients end up in a wheelchair. That's a significant portion. Finally, I just want to touch on this, that, as a nephrologist, there's sort of a dark side of nephrology, and that's, I hope there's no rheumatologists here, but, I depend on them. But you look at a lot of the diagnoses I make with a vasculitis or a glomerulonephritis, sometimes it doesn't make a difference if I make the precise diagnosis at the time. That the treatment, the immunological treatment of steroids, Imuran, Rituxan, it basically treats a whole spectrum of disease. Here, though, if you don't make the right diagnosis, you're going to end up treating the patient wrong, and you have the potential of making the patient worse. So here are some of the other diseases that fall within the realm of HPP, right? We have this whole large category of osteomalacia, which includes stuff like nutritional rickets. It includes vitamin D deficient rickets. But you're going to treat these patients differently. Osteogenesis imperfecta, this intractable seizures. Obviously, if you don't make the diagnosis of HPP, you're never going to treat this patient, right? I don't care what new fancy, anti-seizure medicine you have. If there's not enough vitamin B6 intracellularly, you're never going to be able to stop the seizures. X-linked hypophosphatemic rickets, this osteoarthritis, and then just overall osteopenia, osteoporosis, and then finally periodontal disease. That if you don't have a dentist who recognizes, hey, I shouldn't be losing the whole tooth with the root included, you're going to run into trouble. And I have two cases of misdiagnosis and what can happen, and this idea that even delaying the diagnosis, right, you're going to can have. It's a systemic disease. You're going to have life-threatening and devastating manifestations. So here's an 11-month-old male who presented with failure to thrive. At age 6 months, the patient presented with persistent, a widened anterior fontanelle, and that probably ended up being due to, it's tricky making the diagnosis of craniosynostosis because although the sutures are actually fused, the bone is so weak they still feel open. So it can be very difficult to make that diagnosis. The baby was given the presumptive diagnosis of nutritional rickets, which we've seen a surge in, was treated with high-dose vitamin D and calcium supplementation. So here we are in a situation where that calcium is not able to be utilized, and what do? We tell the body, here's some more vitamin D, here's calcium, absorb more calcium. What's going to happen? Right? You're not going to get that calcium into bone without the actions of alkaline phosphatase. And so what happens? The baby had severe clinical deterioration due to hypercalcemia, hyperphosphatemia, right? They stopped the vitamin D and calcium. There was a persistence of symptoms. And then finally someone paid attention to the alkaline phosphatase, right? They paid attention to that. It was actually at the lower limit of normal, and then looked at some of the radiographic findings, these tongues of radiolucency that went along with the rickets, and HPP was diagnosed. However, you notice here with nephrocalcinosis, this might have been avoidable, right? The deposition of calcium in the kidneys might have been avoidable if someone had made the diagnosis earlier and not treated the baby with calcium and vitamin D. Here's another patient, a tragic patient, so a 4-month-old male with a history of hypercalcemia and intractable seizures. At week 1 of age, had generalized tonic-clonic seizures. And, these patients can be very difficult to manage. Initiated on phenobarbital, Dilantin, but basically continued with seizures. Went through up to 2 months. Patient was noted to have hypercalcemia. At age 4 months, the physical exam was enough to say, hey, there's something not going on, something not right here. They noticed this bulging anterior fontanelle. And then look at that alk phos was 7, with the normal range being 150 to 240. And then basically the baby was given the presumptive diagnosis of HPP. They were started on that form of vitamin B6 that was able to cross over the blood-brain barrier into cells, and the seizures went away. So you can see here's an infant who for 4 months has been treated with every anti-epileptic under the sun, but due to misdiagnosis, the proper treatment was not instituted. So this kind of sums up, how do you put the diagnosis together? Obviously, you have to recognize some of the clinical signs. Whether you have a dentist who's paying attention with that kind of root, the tooth coming out with the root, the skeletal manifestations, and these are not easy to make the specific diagnosis, because we recognize anything that's going to affect calcium and phosphorus metabolism will lead to very similar findings in the skeletal. We also have this muscle and kind of a weakness leading to a systemic disease, respiratory disease, neurologic disease, renal disease, and growth and development, right? So you have to have that high index of suspicion to make the diagnosis. It's a very, very rare disease. So you have to think about the diagnosis in order to make it. Then it's relatively simple. As long as you're thinking about the disease, well, you look at the ALK phos, probably one of the most common laboratory tests out there, still included in the comprehensive metabolic panel. You look, you have to age and sex adjust it, and the later speakers will talk about that. And then if indeed the ALK phos is low, you send off some confirmatory testing. What's a confirmatory testing? Well, you look at other substrates of the tissue nonspecific alkaline phosphatase, specifically vitamin B6. So another very commonly a test that's very easy to send off. I won't talk about urinary PEA. That's a little bit more difficult and esoteric to go. And I can tell you as a clinician, it's something that I'll send off. I don't really pay too much attention, and I'm able to make the diagnosis these days with a low ALK phos and elevated vitamin B6, and then I send off genetic testing in essence. So this is to remind you that, you guys are constantly calling me with high creatinines, high BUNs, high ALK phos. I get a lot of calls about high ALK phos. What do we do? So we spend a lot of time, focusing on this age. Here, we're at the flip side. And especially for children, you recognize that, as children go through these two phases of bone growth, we expect, represents osteoblastic activity. We expect to see these two peaks of ALK phos. Right? So you have to keep that in mind. So looking at an ALK phos for an adult and applying that to a child, you're going to misdiagnose patients. You're going to miss it. You're going to miss it. So you can see in this period of rapid growth, 1 to 10, the low is 156. So you present with an ALK phos of 20, that's abnormal. So someone has to be looking out at this lower range. The lower range has to be included to make the clinician aware. Okay, and then talking about lab values to differentiate between HPP and other metabolic disorders. In almost every other form of rickets, and it's probably due to low phosphorus, which happens in nutritional rickets, also happens obviously in hypophosphatemic rickets, the ALK phos is high, right? That's what I typically get the calls for. It's a high ALK phos, right? I just got a call from the NICU yesterday. ALK phos is high. Can you come down, Dr. Zaritsky? HPP, low. You see a low ALK phos, it should trigger you to say, hey, what's going on here? Let's get a vitamin B6. It's not a very it's not a very difficult test to send off. And you can see the combination of these two, a low ALK phos, a high B6, you've in essence made the diagnosis, right? Oftentimes looking for calcium, phosphorus, PTH, it can be difficult. This is where you really want to focus, right? And that's the name of the disease, hypophosphatasia, right? A low alkaline phosphatase. Now, of course, not every low ALK phos is hypophosphatasia, and so you have to recognize there's other causes. One of them is this, obviously, you're dependent on measuring the activity of the enzyme. If you collect the blood wrong, you chelate out all the magnesium or calcium, or you put it in the wrong tube, you're going to get a falsely depressed alkaline phosphatase. Some of these other medical conditions also can lead to low bone turnover, which also leads to low ALK phos. But you can see I'm not giving you 10 pages of a differential diagnosis here. It's a relatively small subset of diseases that can fool you with low ALK phos. And they're often diseases that are fairly easy to rule out, especially hypothyroidism. Anybody I see for bone disease, I check thyroid. We recognize how systemic the manifestations of hypothyroidism are. Also interesting, just to let you know that this another very rare disease, Wilson's disease, which ends up being very difficult to diagnose for a variety of reasons. Classically, it's not completely understood why. These patients also present with a low ALK phos. Okay, so there's another little tidbit for you to be able to help the clinician on the other side, that when they're looking for the needle in the haystack, which is often Wilson's disease, as opposed to a lot of the other liver diseases. Here, there's a low alkaline phosphatase. So let me summarize. Hopefully I've kind of given you some education about the pathophysiology about HPP. The thing to recognize is it's rare. And with rare diseases, you're never going to make the diagnosis unless you think about it. And the pathophysiology isn't hard to understand. You have an inactivating mutation in the gene encoding the tissue non-specific alkaline phosphatase. Therefore, the biological hallmark is a low serum alk phos. And I'm here, and we're going to beat this into everybody's head today, that you have to pay attention to the lower range. If you go back and you look in your lab's ranges, and there's no lower level of alk phos that's setting off a flag, that's something that needs to change. Okay? We see this systemic diseases. We see different manifestations depending on how severe the mutation is, whether if it's in the perinatal or infantile. But we see this, essentially it's a devastating disease to live with. But there is also a spectrum of disease. So the presentation can be very variable. I think that's it. Thank you very much.
There is a number of references provided at the end of Dr. Zaritsky's lecture for those who want to follow up with some of the articles. So I'm going to give the next presentation. As you saw, appropriate use of reference intervals is really critical to diagnosis of this condition. But as a clinical chemist who has been interested in reference intervals, I also see this as a very important example of why we have to have a good handle of appropriate reference intervals in our lab. Unfortunately, as I'll show you, many labs continue to use reference intervals that are inappropriate, have been determined many years ago on instruments that are no longer used. The hospitals using the same instrumentation across the U.S., across Canada, across other countries are using different reference intervals where even though the populations are largely the same. So there is a huge gap in this area, and that's what I'm trying to highlight in this presentation. So first of all, actually, we have interest in this condition because Canada, one of the first cases of hypophosphatasia was actually was diagnosed in Canada back in the 1940s. This is a case of a 3-year-old boy that was diagnosed with this condition, and through a number of radiological studies, it was characterized, and eventually, actually, this case was published by Dr. Rathman at that time, and was one of the first cases described. But my focus is going to be more on biochemical diagnosis. As we saw from Dr. Zaritsky's talk, alkaline phosphatase is particularly important, is a condition where you see a significant lowering of alkaline phosphatase. This is in contrast to other related conditions that typically cause elevated levels of alkaline phosphatase. And so my focus will be mostly on alkaline phosphatase today. As I mentioned, to diagnose and interpret alkaline phosphatase, but many other tests that we do in a clinical lab, you need to have appropriate reference intervals. Unfortunately, there have been huge gaps in this area in the sense that reference intervals used are either incomplete, especially for children. They're based on a small number of samples. In most cases, studies done used hospitalized or outpatient samples to do the test, the studies, and there were huge other gaps. Methodologies used have been out of date and no longer valid. And this is a common practice, unfortunately, where hospitals change methodology, but they keep using the same reference interval. And this is now becoming a bigger issue, and some of the accreditation bodies are actually looking at trying to ensure labs are using appropriate reference intervals based on the methodology and instrumentation they have. When you get new instrumentation, though, typically you get a reference interval for adults. This is an example of a package insert where, let's say this is ALT, you get an adult reference interval based on also a limited number of adults, but there are no pediatric reference intervals. So this is a problem that is really, the responsibility should be shared between the labs and the industry. In a sense, the industry has not been proactive in many cases, although that's changing now, in ensuring that there are pediatric reference intervals are available as well. So children used to be basically ignored in terms of what appropriate levels are. And so that leads to hospitals use adult reference intervals for their clinical interpretation. But as pediatric clinical biochemists, we always say children are not small adults. And if you look at children, there's huge changes that occur in infancy, in childhood, during adolescence. And these changes can lead to significant changes in biochemical markers that we measure. So you can, for example, see that body weight doubles within the first 6 months, triples within the first year. The body length increases significantly, of course, as the child grows. All of these changes lead to biochemical changes that we have to be aware of when interpreting lab results. So we also see significant changes during puberty, later in childhood and adolescence. So these all affect, and these are all called covariates that can affect levels of analytes, such as alkaline phosphatase. And so therefore, pediatric reference intervals really need to reflect differences in developmental and physiological changes in childhood. So we need to be aware of factors such as gender, age, BMI. We actually have a poster here on factor BMI. Actually, my PhD student Victoria is presenting a talk at 10:30 today, talking about how important BMI is in terms of reference intervals. Sexual development, ethnicity, all of these are important factors that can affect reference intervals that we measure. So actually a study, going back to alkaline phosphatase, a study was done at our hospital by one of my mentors many, many years ago, Dr. Hill, who actually was the previous head of chemistry at our hospital. And he and Dr. Cherian did a study of, this is back in the 1970s and early 80s, where they looked at children and measured alkaline phosphatase. As you can see, they saw huge changes with very high levels early on and then significant drop before the children become adults. Now, if you look at adult reference interval, this is the adult reference interval that was used at the time. And as you can see, there is huge number of children that have high levels of alkaline phosphatase that would be misdiagnosed if one uses adult reference intervals. So this just highlights, and this is not a new finding. And we knew for decades that levels of enzymes such as alkaline phosphatase, but many other tests that we do, are different in many cases in children than in adults. Now, we actually recently did a survey in Canada, and I wanted to show you the result of the survey to highlight that we have a problem as we speak. This is a survey that was done in May of this year, so it's very new. It was done through a task force we have put together called the CSCC. CSCC stands for Canadian Society of Clinical Chemists, task force on reference intervals. And we wanted to try to harmonize reference intervals across Canada. And this task force looked at reference intervals by doing a survey of what people are using for different tests. And we initially did a survey of 7 tests, including alkaline phosphatase. I have a lot of slides, but just going to show you 2 slides to highlight what the problem that we're facing currently. This is actually the data from about 30 334 labs. You can see these are reference intervals. So those lines represent limits, upper and lower limit of reference intervals in one, and we have anonymized the labs, about 34 labs. You can see how variable the reference intervals are, and these are the different instrumentation they're using. Even people using the same reference instrumentation or reagent are using very different reference intervals for alkaline phosphatase. And look, some of the labs are using 0 as the lower limit of normal. And of course, this would be particularly problematic in the sense that it can certainly lead to basically misdiagnosis of conditions such as hypophosphatasia. The shaded area is our recommended. This is, by the way, an example of a 2-year-old male who would be, let's say, go to any of these labs or hospitals for testing. You would get very different interpretation across the country. This is across Canada, from east to west coast of Canada, about 34 labs. Now, we have shown the Caliper reference intervals. I'll talk about Caliper shortly. This is our recommended reference interval for a 2-year-old male. You can see that there is huge differences across the country. Now, if we do this survey today in the U.S., if we do it in anywhere around the world, we're going to see the same problem. So this is not unique to one country or another. It's a major problem that we're facing as lab specialists. These are the recommended harmonized reference intervals by the UK and by Australia. And as you can see, they do correlate well with Caliper, although Caliper reference intervals are tighter because they were determined on healthy children. The harmonized reference intervals are based on discussion and basically consensus. They tend to be wider than Caliper. Now, this is another example of a 14-year-old female who will go to a lab anywhere across the country. Look at the reference intervals being used across the country for a 14-year-old female. So you could see huge gaps in what we're doing currently across the country. And so we really need to get a handle of this. And our task force actually try to work towards ensuring that, let's say, all Beckman users use the same reference intervals, all ortho users use the same reference intervals, and so on. So that would be the starting point around harmonization. So as you can see from those graphs, use of inappropriate reference intervals can be quite basically cause significant risk, and in terms of both diagnosis of the condition and misdiagnosis of the condition, but also it causes increased burden to the patient and to the hospital by increasing risk of further blood collection, doing unnecessary testing if you are misdiagnosing the condition. You would also significantly increase cost of assessment of children with different conditions. So in response to these issues, there have been a number of efforts across the world, and I'm going to focus today on the Caliper program, but there have been a number of other studies around the world that have tried to address this issue, and many of you are aware of those studies. I'm going to focus on Caliper. What we did in Canada, this began about 7-8 years ago, initially discussions around how to address this gap and how to help children's hospitals with appropriate reference intervals. And so we're here in Toronto, but there are a number of other centers initially collaborated. Now we have additional centers who have joined this study, but this is a list of the original 7 or so hospitals that were involved. Our goal was to establish a very comprehensive database of covariate stratified reference intervals in a sense that we wanted to have a very comprehensive database that will be freely available online as well as in peer-reviewed literature to labs to use. And I'm happy to say that in the last 5 or 7 years, we've been able to mostly achieve that goal. Now, one of the first, of course, the most difficult part of this was recruiting healthy children. So there was a significant effort. It took over 5-6 years to recruit thousands of children across, particularly in the Greater Toronto area and Hamilton area. So it was mostly in the Ontario region. But we also collected from different ethnic groups other than Caucasian. We have a large South Asian and East Asian population in Canada, and we collected, and we have actually done some ethnic comparisons as well. I won't have time to talk about that today. So we've been going to schools, we've been going to community centers, and we've been basically convincing families to participate. And I'm happy to say that children and families have been particularly receptive and helpful. And we actually were able to collect, as of today, over 9,000 samples from 9,000 healthy children who have completed, with the help of volunteers, have completed questionnaires and consent forms. And then the samples have been collected, largely serum samples. This created a biobank, Caliper biobank, and we use this to do a lot of testing, and some of which you have, I'm sure, seen the publications for. We also have a lot of health information collected, which is very helpful. And that's why we're now looking at some of these factors, for example, BMI, ethnicity, and so on. These are some of the original publications that have been published. There is about 18 publications now, actually, on Caliper, that where we have looked at various parts of the data. So initially was the major paper in clinical chemistry, but then in 2012, 2 in 2013, and another in 2014, and other journals such as Clinical Biochemistry, CCLM. So you can access all of these papers through the website, the Caliper website, caliperproject.com. So they're all listed there. So this has led to a development of an online database of actually over 100 biomarkers. About 80 of them are now online. We're adding additional markers that we have studied. We wait usually for the papers to be accepted, the data to be peer-reviewed before we put it online. And so the online database allows you to go and select a test, select the instrument that you're using, and then you get a table of reference intervals, and you also get a graphical scatter plot of the data. You can see how levels change in children from birth to 18 years of age. We have also recently developed an app that's available through iTunes and Google Play, and I encourage you to try to use the app because it's quite useful for a laboratorian, for a fellow or trainee, and for clinicians, pediatricians, and family physicians. Now, quickly, I'm going to show you there's a lot of data that Caliper has generated, but I'm just going to show you the alkaline phosphatase data and calcium and phosphate because these are particularly relevant. This is the data from Caliper published in 2012. You can see the alkaline phosphatase levels. It's in about 2,000 children. You can see that levels are quite variable early after birth, but then stabilize, but it's still quite high, are elevated further in adolescence, and then levels drop very rapidly to adult levels by 18 years of age. So you can see significant differences across the different age groups, but also you see a significant gender difference as well, particularly in adolescence. So you really need a big data set to be able to see those changes and then be able to use the data to stratify and partition based on age and gender. And so that's what we did, and we were able to partition and have reference intervals for different age groups. I have to say that I should emphasize, as you can see, hardly any children has reference levels below 100. Many labs, though, as we speak, are using reference intervals that are much lower than that, levels that are much lower than that. Even some are using a cutoff of 0 for a lower limit of reference interval. So now, of course, you can see that you're going to miss a lot of children who might have low levels of alkaline phosphatase. Now, in this cohort, we have measured over 100 markers. 2 other markers relevant to this today's topic is calcium and phosphate. You can see calcium levels are very stable across the age group. So we are born with a certain calcium level, and it's very stable across. Actually, we have done adults recently through another study and called CHMS, and we see the same calcium level continue until 80 years of age. So this calcium is very tightly regulated. It's like an electrolyte. But phosphate, on the other hand, there is a significant drop with age. And so again, you need to know that to be able to appropriately partition the reference intervals for phosphate. Now, this is a slide that was shown by Dr. Zaritsky. Basically, that's the Caliper data has now been used to determine these cutoffs for different age groups and genders that could be basically used for more appropriate diagnosis of this condition, hypophosphatasia. I wanted to also show you, we actually compared all 5 major instruments, and I wanted to show you how different instruments compare. The original data that I showed you was on Abbott Architect alkaline phosphatase assay, but we now have compared Abbott to all these other systems, so because each hospital may use a different system. But you can see this is actually for a 0 to 14, the reference range for first 2 weeks of life. You can see not a huge difference. There are minor differences, but not huge. You see the same type of comparison. Beckman levels tend to be slightly lower, but it's still very, very comparable across the instruments. So using different instruments is not an excuse for you using inappropriate reference intervals. They actually compare quite well. But unfortunately, many labs feel that because I use this instrument, I can't change my reference interval or update my reference interval. But the reality is that there is actually very good comparisons when you look at different instruments. This is for the 1 to 10-year-olds. Again, very closely associated levels. This has been published, by the way, in actually a couple of years ago. Now, I should say that we also did, as part of this task force on harmonization, we also did a survey through Dr. David Succumb's SQL program, and where a single sample was sent to about 39 labs across the country, and they measured alkaline phosphatase, but they measured a few other tests as well. But I'll just show you the alkaline phosphatase levels. You can see that we not only have a reference interval problem, we also have a problem in terms of calibration. You can see there are the target for this was based on a reference method. It was determined to be 73. The level should have been read as 73, but you can see that there was significant variation in what levels were being measured by different labs across the country. So particularly problematic was the Beckman users, but you can see significant variability with others as well. Only some labs were able to meet the target. So there is a calibration problem as well as a reference interval problem with labs. The problem being that we use multiple assays per test, and there are differences in calibration of each test. And so this, of course, calls for really efforts by AACC, by CSCC, by other bodies, IFCC, to try to help with harmonization of not only methods, but also reference intervals. So that's what we're trying to do now. One of the future goals of Caliper is to try to help harmonize reference intervals across the world, starting, of course, with Canada. Okay, that ends my presentation. I just wanted to thank many people. Caliper has been is really a team project, a huge number of investigators across the country, and many industry colleagues and funding agencies have been involved. Thank you very much. So we're going to move on and go to our last presentation, but not least, by Dr. Kellogg. Dr. Mark Kellogg is the Associate Director of Chemistry at Boston Children's Hospital and Assistant Professor at Harvard Medical School. And he's going to talk to us about the AACC initiative.
So I'm going to give you a quick update on the AACC activities in the pediatric task force, in our task force, and where we stand with that. So like Caliper a few years ago, AACC members recognized that we needed to do something about pediatric reference intervals. And so we started the Reference Range Initiative at our annual meeting when it was in Orlando. So that was our first get-together. Led to some change, some goals that were created, more research in this area, and we're kind of still there today. Educate the key stakeholders, get the message out, foster more collaboration, more data sharing so that we could have an easier task of getting these reference intervals into our laboratories. And then the Pediatric and Maternal Fetal Division took that on as part of theirs, and then there was the committee created within that structure. So we looked around, what kind of databases or resources were out there available for us to do this work, and NIH was starting the National Children's Health Study. We thought that would be a great opportunity. They were going to be collecting samples from lots of kids. It wasn't designed to be a reference interval study like Caliper, so this was sort of a sub-piece of that study. You can kind of see the location or what their plans were on this graphic here. We were lucky enough to actually, get some of the samples, and some members of the reference interval were able to get some blood spots. So one of the things with that study that I didn't point out is it was longitudinal. So we started with the 0, got the 1 year, 2 year. We would have gotten the teens later on. So that was one of the problems with the study. But we were able to get samples, did some pilot study, and new reference ranges for amino acids and steroids were generated from that. Unfortunately, in 2014, Congress decided that funding for the National Children's Health Study should be discontinued. There were several different issues with the study. One related to us was the biobank wasn't funded, but collecting samples was funded. So, they have to change some of those things. So now we don't have that study to go back to. It has been replaced with a different study, the environmental influences, or ECHO, but it's basically going to use existing data. So it's not a new study to go back, and so we won't be able to grab samples from that, unfortunately. And their focus areas are targeted into airway, obesity, some peri-postnatal outcomes, and neurodevelopment. Probably some opportunities for us in there with the existing data, but again, basically we've lost the opportunity to work with this resource. So that would have been the end of my talk in June, but in July, AACC put together a position paper trying to get all of us motivated to let's fix this issue within the U.S. and what AACC can do. So early July, the position paper came out titled Pediatric Lab Results, the Need for Normal, and the big thing is their access to those samples from healthy children significantly hinders what we need to do to establish good reference intervals. So Khosrow and his colleagues have gotten the Caliper database available, those samples available. That's a great resource for us, but there are ethnic differences, regional differences that we have to account for, and so within the U.S. we also need to do that. So as AACC members in our organization, we need to work with our Congress people, let people know, and so then several recommendations. So one, Congress should mandate and fund a national repository sample so that we have those samples like the Caliper database so that we can go access those, do our own studies, get that data to improve our reference intervals. How many of you have ever reached out to your congressman? or woman? Senators? Nobody? A couple of people. I encourage you to do so. It actually works. They call you back. And no, they do. It may be a staffer, but it's a staffer who, in most cases, in my experience, they understand science. Senator Warren has called me back when Senator Kennedy was there. He called me back when I would send just emails or even letters, handwritten letters. It does work. So do it. Reach out. Take the position paper to them. Send them the position paper. Tell them how important this is, and we can get this moving. So in the position paper, things that are important to understand: the age, developmental stage. Khosrow's gone through a lot of these things. Ethnicity, gender variations. All of those things need to be part of it. We just can't have a small group of, homogeneous individuals in that database. The availability of those specimens for us to do these studies. It requires informed consent. Part of it is due to the technological changes. How many of you have opened the Pediatric Reference Interval textbook? Okay, a few people. What were the years for most of those studies, and what instrumentation was done on that? I mean, they go back into the 80s, with the RA 1000. How many have used that? They don't exist anymore. Some of the chemistry is the same, but the technology's changed. Informatics need to be part of this, that database. Khosrow has the available database, the apps. That's the informatics, so that that info can get out. And the need for that national registry. So these are the things that AACC put in the position paper, things that you can talk to your congresspeople about. Samples have to be in a repository, well collected with informed consent, available to the manufacturers. So this is the other group that you need to reach out to. How many manufacturers in the audience? None? Oh, okay. So that's part of our job. Reach out to those manufacturers, help them do that work, because I'll admit it, it's difficult to do these kind of studies. The manufacturers are really going to have to be the ones to help get that large data set on their instruments. We can do our reference interval, transference. Manufacturers and clinical labs should report that data back into the repository with the analytical methods used to determine them, so that everybody has that available, so we can work together, we can share on that. So that consensus that most of us have to use to reach what our reference interval is in our institution for our methodologies is a better consensus, because we've got more data to work from. Samples have to be de-identified. The de-identified residual samples still need to be available. If you've followed some of the IR or work that's going in this space with human research, they've talked about removing this de-identified samples from our ability to use in the clinical laboratory. So this is another important thing to lobby with your congressional people. Under HIPAA, de-identification may mean we would not have those samples. We couldn't go and get those samples. We're going to discard and use those for QA or research like this for reference intervals. Standardization, as Khosrow already pointed out, is important. Although the differences between instruments are small, they are there. We need to worry about that. AACC also has another large initiative in harmonization. IFCC does, so that's part of also this, because it's important for our intervals that standardization is there. And again, collaborate, transfer, those mechanisms need to be part of the whole process. We just can't have one group doing it here, another group there, and not sharing all of that information. So the Pediatric Reference Range Committee no longer exists. It was disbanded, but AACC continues to promote the need for this within the Pediatric Maternal Fetal Division. The position paper that's put out there, if you're not aware, Dr. Jones, the current president, is a pediatric clinical chemist. So there's a lot of efforts still ongoing to make this happen, but we need your help. Reach out to those congressmen, congresswomen, and let them know that the lack of that National Children's Health Study has a significant impact on what we can do in helping keep kids healthy. All right, so that concludes that phase. And I think the other speakers were going to come back and answer questions.
Dr. Gar.
What was it? I'll repeat. Are there? was that last word?
Milder.
Oh, milder forms. Yeah, when you look at the, and I didn't have time to get into this. There is what we see as a genotype kind of phenotype, or a dose response, for example. So we'll see some patients who, for the vast majority of the patients, and especially the severe patients, it's an autosomal recessive disease with 2 missense mutations being present. We will recognize, though, that there are some other patients who, have only 1 mutation. Typically, they're clinically silent, those patients. There are some very, very rare forms of autosomal dominant, but it's a spectrum of disease. So the question is what, sometimes it's very clear, right? We see this huge phenotype and we see a very low alk phos. Other times we see, an alk phos that isn't necessarily very low, or it's the lower limit. And that's, I think, where genetics really kind of helps out tremendously. So, my colleague and I have been puzzling over a child who, came in, had a fracture due to real trauma, but had a low alk phos. And then we went to the genetics and found out that indeed had a missense mutation, but was only heterozygous for it. And so probably, like looking at the rest of the phenotype isn't there. We don't see any abnormal mineralization or anything like that. So the very clear case is a low alk phos is going to help you. I will mention one other thing is that you have to recognize that, there's natural increases in alk phos, especially after a large fracture of a long bone. So sometimes, you have to, it can be tricky because if the child comes in with a fracture and the alk phos might still be at the lower limit of normal, but you have to follow serial alk phoses. So, and you have to be looking for a pattern. You just can't rely on any single one value. I hope that answers your question.
Okay, we have a few questions here submitted. I'm going to read them. First, Dr. Rao has asked 2 questions. Does these reference interval studies have race-based ranges established? We did, with Caliper, we did some preliminary analysis comparing Caucasians in Canada to South Asians and East Asians, mostly Chinese Canadians. And we actually showed that for some tests there are differences, but fortunately for the majority of tests done, out of about 70 tests we had looked at, most of them did not show any ethnic differences, but there was about half a dozen, about 10 tests that did show some significant differences. But that was based on preliminary analysis. I'm happy to say that we're starting a larger ethnic comparison study with Caliper. We're going to be collaborating with Dr. Kellogg, Dr. Uttam Garg, and other centers in the U.S. So we do a Canada-U.S. joint study of ethnic differences, so we can actually be able to have North American data in the future. The second question is, does the analysis include mass spec-based methods? Yes, we have actually published some mass spec reference intervals as well, and that work continues. So we have looked at, for example, amino acid profiles, acyl carnitines by mass spec. We have done also a steroid panel by mass spec. So those have been published.
I wonder if also for, and you can help me out, it's not commonly sent off, but at least for urinary PEA, I think that might be a mass spec. And that's something that I usually have to work with the people in the lab to say, hey, I want to order this. It's not something that's normally reported. It's measured but not reported. So they have to be willing to, give up that data.
Thank you. You're actually the test that test is not readily available, which is only a few centers are able to provide it. We have some additional questions here. Maybe we'll share these questions. Would you like to go with those?
It's a question, how many samples that are needed to verify reference ranges? That's actually a question I wanted for the audience. How many of you have verified your reference intervals? All right. I'll admit I don't do it for all of mine because it's difficult. So if you look at the CLSI guidelines, ideally you try to find 20 healthy individuals And if you run those, and as long as 18 out of the 20 fall within the interval that you wish to adopt, then you can adopt that interval. But finding 20 healthy kids means male, female, all of those different categories for whatever analyte you're looking for. And then, in our case, and sometimes we're not looking at just 20 kids, we're looking at 40 at a minimum, so we get male and female, but then all those different age categories that it may fall into. So I may be looking at several hundred or 1,000, and that's where it becomes difficult to do that verification.
You think it just, I'm curious about this, learning from the other side, is just thinking about ALK-Phos. If you look at the reference range, so what do you do? Do you get male and female 0 to 1, 1 to 10? How many samples do you need to test? Let's say you get a new machine or a new assay.
Ideally 20 in each of those bins.
Yeah.
So, but if you're going to, ideally you have to. It doesn't say that, but if you think about it, I just can't take 0 to 18 and take 20 kids, because statistically that doesn't really help us at all. Yeah. Right. And that's actually what we end up doing, but that means our data isn't that good. And most of our reference intervals at Boston Children are consensus. We do some of that. We sit down with the physicians that are most impacted by that analyte, and we look at the literature and we create our own consensus intervals. Luckily, Caliper is providing a much better database for us to start to do that from. Do you have hematology reference ranges?
Caliper collaborated on another study that was published in Clinical Chemistry, August issue of last year. So I sort of encourage you to take a look at those publications. One of them, there were 3 papers. One of them is on hematology markers. It was measured in Canadians, about 12,000 Canadians, from 3 years to 80 years of age. So that includes adults and children. So we do have new reference intervals for hematology, not Caliper, but another study that was done by actually the government of Canada. Please.
I just want to say that we were probably the poster child for how to do it wrong that did reference range trial. We had 24 all across the board, adults, all ages of kids. Well, about 9 months ago, one physician to do specialized in this. And as a result, the Caliper work plus what we did was looking at maybe 10,000 of our ALK-Phos results on children and try to eliminate the diagnostic categories that might affect this. And manipulate it with.
Good God. Jeez. I'm okay. I hope you all are. I think they turned on the microphone. But it was very helpful to have the Caliper data with that, because I'm not a big fan of looking at results from diseased people and trying to make normal ranges out of it. But in this case, it really helped, because it's obviously the good thing is it's our own exact analyzers. So, but certainly the Caliper has been tremendous. So, thank you.
Well, thank you. I have to say that we did compare Caliper data to hospital retrospective data, and our finding, which was published, was that if you use community outpatient data, that might work. But for hospitalized or hospital, especially tertiary care patient data, doesn't work. The levels tend to be, most of those children are very sick, and so using hospital data that, especially tertiary care, acute care hospital data may not be as useful. But if you have a large outpatient community sample database, that might be helpful to derive reference ranges from. We'll move to the last couple of questions. When do you anticipate the manufacturers to update Caliper into their PIs? Well, actually, I know Abbott has been trying to get FDA clearance to include Caliper reference intervals in their package insert, but it does require a lot of regulatory steps, and that's been the delay. Beckman also is trying to do the same. So we have been working with all of the main manufacturers to try to get them to update their reference intervals. Unfortunately, including them in their package inserts requires a lot more sort of administration regulation that has been delaying the implementation. The last question is, will CLSI mandate Caliper across all labs? I'm not sure about Caliper, but certainly I think regulatory bodies must get involved. So I think they need to say to labs, whether it's in US, Canada, or elsewhere, they have to say that you got to use the best available data and not rely on your old archival data that may no longer be relevant. So I think there needs to be accreditation body involvement to get the labs to move and change and update. We're actually trying to work with the Canadian accreditation bodies to make that happen in Canada. But I think if AACC initiative takes off and there is also US data that can be compared to Caliper, that will be additional incentive to mandate it perhaps through CLSI or other bodies. Would you like to comment, Mark?
I think it's important, though, to note that CLSI doesn't mandate anything. CLSI provides our best practices, the guidelines. The regulators will be the ones who will mandate. And again, reaching out to our, the regulators, our accrediting bodies, Congress, and pointing out, why it's important to these things. CLIA already says we have to establish those. So if you think about it in the U.S., that requirement's already there that we're mandated to have reference intervals. They don't do the details, so that's where CLSI comes in, and actually the existing document is very nice guidelines on how to do that process. So then the argument would be that the regulators accreditors would say, well, here's best practice, you're not doing best practice, so there's sort of the teeth to it right now. But improving that, that goes back to, yes, the regulations say we have to establish that. CLSI has provided us the best practices on how to do that, but we don't have the samples. We don't have the biorepository. We don't have the informatics, which is why AACC put out that position paper so that we can get the rest of all of that has to go together.
Well, thank you very much.